In this video, I will discuss the definition of hypertension, the mechanism of action of different antihypertensive medications, the underlying causes of hypertension during pregnancy, and finally, the safe treatment options that are available for pregnant patients. So hypertension can be divided into two different forms: primary, where there is no identifiable cause to it, and the risk factors to primary hypertension include obesity, which is the #1 risk factor. Other risk factors to primary hypertension include high salt diet, smoking, diabetes, genetics, advanced age, and race, where black people have higher blood pressure than white people. And then the underlying causes of secondary hypertension, there is a disease that can lead to the increased blood pressure. For instance, there could be a renal disease or renal artery stenosis, and thus it would cause hypertension. And other causes could be like from pheochromocytoma, which is a tumor of adrenal medulla from which there would be increased production of catecholamines and cause hypertension. Other causes include, for instance, Cushing's disease, where due to the increased production of steroids, there is high blood pressure. Conn's disease, which is a tumor that is producing aldosterone, can also lead to the hypertension. Obstructive sleep apnea is another cause of secondary hypertension. And finally, coarctation of aorta in young children can cause hypertension in the upper extremities. Next, I would like to go over the mechanism of action of different antihypertensive medications, starting with the diuretics. So diuretics can be divided into three different categories, including the loop diuretics, thiazides, and potassium sparing diuretics. So if you have a glomeruli here that then goes to the proximal convoluted tubule, loop of Henle, distal convoluted tubules, and then collecting tubules, the loop diuretics will work on the thick ascending loop of Henle, while thiazide will work on the distal convoluted tubules, and then finally potassium sparing diuretics will work on the collecting ducts. So starting with loop diuretics, these medications include, for instance, etacrinic acid as well as furosemide. And what they do is that they block the sodium 2-chloride potassium channel in the thick ascending loop of Henle, and thus it will inhibit the concentrating ability of the urine. So these medications are usually used as water pills for conditions like congestive heart failure or pulmonary edema, or in patients that have ascites. And what it does is that they help get rid of some of the fluids in these patients. The side effects of these medications, for furosemide for instance, it include ototoxicity. They also cause hypokalemia, and gout is also another side effect of loop diuretics. The next classes of diuretics are thiazides, which inhibit the sodium chloride absorption in the early distal convoluted tubule. In addition, these medications decrease the excretion of calcium, and thus they are good for treatment of hypertension in patients that do not have any other medical conditions, or in patients that have osteoporosis or renal stones. And then the side effect of thiazide diuretics is hypergluc. So it would cause hyperglycemia, hyperlipidemia, hyperuricemia, and then hypercalcemia. And this property of hypercalcemia is good for the treatment of patients with osteoporosis, and since there is decreased excretion of calcium in the renal tubules, it also prevents development of renal stones. And then one other point I would like to mention is that thiazide diuretics, as well as the furosemides, these are associated with sulfa allergy. The next group of diuretics are potassium-sparing diuretics, which include, for instance, spironolactone or eplerenone, both of which are the aldosterone antagonists. And then the other medications include triamterene and amiloride, both of which block the sodium channels in the cortical collecting tubules. So just keep that in mind. Spironolactone and epranolone are the aldosterone antagonists that work on the cortical collecting tubules, while triamterene and amiloride are blocking the sodium channel in the cortical collecting tubules. All of these medications are categorized into the potassium-sparing diuretics. And then the side effects, as the name implies, potassium-sparing includes hyperkalemia that can lead to arrhythmia. And then spironolactone has anti-androgenic effects, and thus it can cause gynecomastia. Next, we have beta blockers like propranolol or metoprolol, and the function of beta blockers is 1, to decrease the cardiac contractility, and 2, decrease the secretion of renin. Now there are different groups of beta blockers. The ones that are starting with the letters B, E, A, M, BEAM, are alpha-1 selective antagonists. Examples include, for instance, betoxolol, esmolol, atenolol, ACE, butolol, and metoprolol. So what happens is that with beta blockers, they could inhibit both beta 1 and beta 2, and thus you cannot use all of these beta blockers in patients that have asthma. However, there are certain beta blockers that are beta 1 specific, and these are starting with letters B, E, A, M, like the ones that are listed here, and these will only act on beta 1 and thus spare the beta 2 receptor. So you can use these classes of beta blockers in patients that have asthma. There is also another classes of beta blockers that, in addition of acting on beta 1 and beta 2, they also block the alpha 1 receptors. So examples of these medications include carvedilol and labetalol, which block alpha 1, beta 1, and beta 2, and thus they would decrease blood pressure without causing a rebound tachycardia, because they would dilate the vessels, but at the same time they stop the heart from beating, so it would not cause any rebound tachycardia. Now, in general, beta blockers, these are excellent antihypertensive medications in patients that have CHF or are post myocardial infarction, and the reason for that is that these medications extend lifespan in these patients. However, you should also be aware of the side effect of these medications, which include, for instance, bradycardia, asthma exacerbation in those that are acting on beta 2 receptors as well. It can cause impotence. It can cause masking of hyperglycemia. In diabetic patients, metoprolol causes dyslipidemia, so it will worsen the lipid profile. And then finally, propranolol will cause vasospasm, and thus you should avoid this medication in patients that have Raynaud syndrome. The next classes of antihypertensive medications include central alpha-2 acting agonists, including the alpha-methyl dopa, as well as the clonidine. And one advantage of these medications is that they do not affect the renal blood flow, and thus they are useful for the treatment of hypertension in patients with renal disease. The side effects of these medications, however, include orthostatic hypotension. Alpha-1 antagonists are the next classes of antihypertensive medications, and these are divided into two classes: the non-selective, which include the phenoxybenzamine as well as the phentolamine. So phentolamine is used for the treatment of hypertensive crisis in patients that are taking the antidepressants, monoamine oxidase inhibitors, and at the same time they were taking tyramine containing foods, like for instance cheese or wine. And once these patients develop a hypertensive crisis, you can give them phentolamine to reverse the effects. And then phenoxybenzamine is used for the treatment of patients with pheochromocytoma, which is a tumor of adrenal medulla. So in these patients, they produce too much catecholamines and cause hypertension. The treatment is surgical removal of the tumor, but before doing that, like about 10 to 14 days before removing the tumor, you have to provide these patients with phenoxybenzamine. It will cause expansion of the vessels. The body notices the decrease in blood pressure and expand the blood volume. So once you remove the tumor, since you've already prepared these patients, they won't develop hypotension. But if you don't give this medication and remove the tumor right away, these patients will become severely hypotensive. And then the next classes of the alpha-1 antagonists include the selective alpha-1 blockers, which include, for instance, the prazosin and tamsulosin. And the function of these medications is to relax the smooth muscles. And thus they are extremely good for the treatment of urinary retention in patients with benign prostatic hyperplasia. For the same reason, since they relax the smooth muscles, they are also useful in helping patients to pass renal stones. Next, we have calcium channel blockers, which are again divided into two different types. The dihydropyridines, like for instance amlodipine or nifedipine, and then the non-dihydropyridines like diltiazem and verapamil. So the dihydropyridine drugs will specifically act on the smooth muscles and help decrease the blood pressure, while the non-dihydropyridines like diltiazem and verapamil, these will act on the heart and thus decrease the cardiac output, and through this mechanism they would decrease the blood pressure. And then the side effect of the calcium channel blockers include, for instance, constipation, peripheral edema, as well as the flushing. Vasodilators are next, an example of which is hydralazine, which increases the cyclic GMP that cause relaxation of the smooth muscles, and thus it will cause vasodilation of the arterioles, as a consequence of which there would be a decreased afterload, and thus there would be a compensatory increase in the heart rate. So therefore these medications should not be used in patients that have angina or myocardial infarction, because they, despite decrease the blood pressure, because there's a rebound increase in heart rate, they could worsen the angina or myocardial infarction. ACE inhibitors and angiotensin receptor blockers are the final two antihypertensive medications we have here. So an example of angiotensin converting enzyme inhibitors include lisinopril or enalapril. So what these medications do is that they block the aldosterone formation, and thus they reduce the peripheral resistance. However, by blocking the angiotensin converting enzyme, there would be an increased level of bradykinin in these patients, which can cause cough and angioedema. And then since there is a decreased perfusion of the renal vessels in these patients, they could also cause hyperkalemia. And then you should avoid these medications in patients that have renal artery stenosis, because as I mentioned, they decrease the renal perfusion, and since there is already renal artery stenosis, they could decrease the level of perfusion of the renal vessels to a point that can damage the kidneys. In addition, you can also avoid it in patients that are pregnant, because it can destroy the fetus renal development. However, these classes of medications are extremely good for patients that are having congestive heart failure or are post-myocardial infarction, by the fact that they both cause vasodilation and venodilation. So by vasodilation, ACE inhibitors will decrease the afterload and the work of the heart. And then by venodilation, they also decrease the preload as well as the work of the heart. So therefore, ACE inhibitors increase lifespan in patients that have congestive heart failure or are post-myocardial infarction. In addition, ACE inhibitors are extremely useful for diabetics, because in diabetic patients, too much perfusion of the renal arteries can cause the renal damage. However, by decreasing the renal perfusion via ACE inhibitors, you could prevent the renal damage in patients that are diabetic. So just keep that in mind. ACE inhibitors are good for patients with congestive heart failure, post-myocardial infarction, as well as patients with diabetes, but you should avoid it in patients that are pregnant or in patients with renal artery stenosis. And then next we have the angiotensin receptor blockers. So by directly blocking the angiotensin receptor, these classes of medications, an example of which is losartan, do not increase the level of bradykinin. So these medications are not associated with any cough. So if you have a patient that is on ACE inhibitors and complain of a dry cough, they say they cannot take it anymore, then you can consider switching them to losartan. And now we are done with the explanation of the mechanism of action of different antihypertensive medications. Next, I would like to go over the electrolyte changes with the diuretics that I've just explained here, loop diuretics, thiazides, and the potassium-sparing diuretics. So here I've provided you with a table that goes through every one of them. So with the loop diuretics, there is an increased secretion of urine sodium chloride as well as potassium as well as calcium. And since there is already too much excretion of potassium in the urine, the H+, K+ exchanger will absorb some of the potassium in exchange for hydrogen ion. And thus, since hydrogen is being excreted, the pH of the body will keep increasing. Same with thiazide diuretics, they increase the excretion of sodium chloride and potassium, and thus they would increase the body pH. However, the difference is that the side effect of thiazide diuretics was hyperglyc. So it causes hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. So since there is a decreased excretion of calcium in the urine of these patients, therefore they would be prone to developing hypercalcemia, and thus these medications are excellent for treating hypertension in patients with osteoporosis or with recurrent renal stones. And then finally we have the potassium-sparing diuretics, which by blocking the Na+, K+ exchanger, Na+ cannot be absorbed, and thus there would be increased urinary excretion of sodium chloride and decreased urinary excretion of potassium, and thus there would be a decreased body pH in these patients through the same mechanism that I've explained here. Next, I would like to go over the mechanism of ACE inhibitors, angiotensin receptor blockers, and the beta blockers. So here you can see that ACE inhibitors like lisinopril inhibit the angiotensin converting enzyme. So the angiotensin converting enzyme itself will block the production of bradykinin. So if you block the ACE, therefore there would be an increased level of bradykinin in these patients, which can cause cough and angioedema as a side effect of this classes of medication. Now, since there is a decreased production of ACE, therefore there would be a decreased level of angiotensin 2 and aldosterone from this point on. So from this point on, everything will be decreased. However, because there is a positive feedback to increase the production of whatever is behind from wherever there was a block in the pathway, therefore there would be an increased level of angiotensin 1, angiotensin, and renin. Same thing applies with the angiotensin receptor blockers. You inhibit the receptor right here, so everything that is behind the pathway would be increased as a positive feedback, while everything that is in front of it will be decreased. And then unlike the ACE inhibitors, since the angiotensin receptor blockers have no effect on the ACE, therefore there will be no change in the level of bradykinin, and thus there is no cough production in patients that are taking angiotensin receptor blockers. And then finally we have the beta blockers, which decrease the secretion of renin, so they block the pathway right here. There would be a positive feedback to increase the level of angiotensin production, but everything in front of this pathway would be decreased. And then again, by not changing the levels of angiotensin converting enzymes, there's also no cough associated with beta blockers. Alright, now next I would like to go over the classification of hypertension. So if the blood pressure falls in between 140 to 159 systolic over 90 to 99 systolic, then that would be in stage 1 hypertension, which is a mild hypertension. Blood pressure of 160 systolic over 100 diastolic is considered as stage 2 or moderate hypertension. And then finally, conditions that have diastolic blood pressure of more than 120 is considered as hypertensive urgency, where the patient is asymptomatic, or hypertensive emergency, where the patient would be symptomatic due to end organ damage. And then examples of end organ damage include retinopathy, intracranial hemorrhage, aortic dissection. It could include the left ventricular failure or pulmonary congestion. And then finally, we could have renal failure from malignant nephrosclerosis. So there are different classes of medications that can be used for the treatment of hypertensive emergency. And these medications, for instance, include labetalol, which could be used for retinopathy, phenyldopa, as well as nitroprusside. For patients that have intracranial hemorrhage or aortic disease, in other words, in those that have vascular accidents, you want to decrease the blood pressure without causing reflex tachycardia. For instance, if you give these patients hydralazine, you would decrease the blood pressure, but since there would be a reflex tachycardia, their conditions would be worsened. So the medications that you can give these patients to decrease the blood pressure without causing reflex tachycardia include labetalol, which acts on both alpha-1 receptors as well as beta-1 receptors. So therefore, it decreases the blood pressure via the alpha-1 while it prevents the reflex tachycardia by blocking the beta-1 receptor. For patients that have the left ventricular failure or pulmonary congestion, you can provide them with the nitroprusside to cause vasodilation and thus decrease the afterload and the work of the heart. And then in patients that develop renal failure, for instance, from malignant nephrosclerosis, and thus there would be a decreased renal perfusion, you can provide them with phenyldopa, which will relax the renal vascular smooth muscles and thus increase renal perfusion. Next, I would like to discuss different classes of medications that you can use for the treatment of hypertension during pregnancy. So during pregnancy, you got to be careful to provide a medication not to harm the fetus. And you have to avoid ACE inhibitors as well as angiotensin receptor blockers because they would cause the renal dysplasia of the fetus, and thus it would cause oligohydramnios, as a consequence of which they would develop Potter's syndrome and their lungs may not develop, and thus they can cause death. So the classes of medications that you can use for the treatment of hypertension in pregnancy: one, you can give magnesium sulfate to prevent seizure development in patients that have preeclampsia. And then the other safe classes of antihypertensive medications include methyldopa, hydralazine, labetalol, or calcium channel blockers like nifedipine or nicardipine. So different causes of hypertension in pregnancy include, for instance, preeclampsia, which is characterized by the new onset hypertension with either proteinuria of more than 0.3 gram in 24 hours or end organ damage, all of which happen after 20 weeks of gestation. And the reason for preeclampsia is that there are abnormalities with the placental vasculature where the placenta does not perfuse completely, and thus the body will increase the blood pressure to be able to perfuse the placenta, as a consequence of which there would be proteinuria, increased blood pressure, headaches, visual problems, nausea and vomiting. Other causes could include, for instance, altered mental status, fetal growth restriction, and oligohydramnios. since the placenta is not being perfused completely. Risk factors to preeclampsia include chronic renal disease, high blood pressure prior to pregnancy, diabetes, multiple gestations, and black race. And then for the treatment of these patients, usually your goal is to bring the blood pressure below 160, 110. Now, one purpose of providing magnesium in these patients that have preeclampsia is to prevent seizure development. However, if a patient with preeclampsia develops seizure, then the definition changes to eclampsia. So eclampsia is a grand mal seizure in a patient that previously had preeclampsia. HELP is the more severe form of preeclampsia, which presents with hemolysis, elevated liver enzymes, and low platelets. So HE goes for hemolysis, EL goes for elevated liver enzymes, and then LP goes for low platelets. And then finally, if a patient presents with high blood pressure after 20 weeks of gestation without either proteinuria or end organ damage, then the definition is just simply gestational hypertension. So for the treatment of preeclampsia, as I mentioned earlier, you will have to bring the blood pressure below 160 over 110. And then you can provide these patients with magnesium sulfate for seizure prophylaxis, and then betamethasone to enhance fetal lung maturity. So by providing betamethasone to the mother, the fetus will increase the production of surfactant, and thus the lungs would be mature at an earlier time. So in case you will have to induce the labor at an earlier time, if you give the fetus betamethasone, you would be ready for that, and thus you won't cause any fetal distress after the birth. And then one final point I would like to mention here is that patients that you've provided magnesium sulfate, you will have to watch them closely, because the toxic effects of magnesium sulfate include respiratory paralysis, cardiac arrest, as well as loss of deep tendon reflexes. So if you're providing these patients with magnesium sulfate, you can go and check their deep tendon reflexes every once in a while, just to make sure you've not overdosed them and you're not causing any problem. And then if you notice that you're causing problem, then you can discontinue magnesium sulfate, or if you feel that there is a risk of cardiac arrest, then you can provide them with the calcium gluconate. And that concludes our discussion.